We are very happy to continue the program, and I think we are going a very, very exciting program after the lunch period, the first session, and actually Miklo Shakintot is one of my co-chairs, and it's me. I don't think so that we need to introduce ourselves. So, but first of all, concerning the first speaker, I don't think so that anybody in the room is to introduce Thomas Gress, because he's one of the top or the best experts in pancreatic cancer field. He has unbelievable high profile articles in the past. He is also in plenty of places, top leaders in pancreatology, also the associate editor of the pancreatic field at gut. And I'm more than happy that Thomas could accept our invitation. Only we can have him today online, but still I believe that what he will show us and what will introduce us will be really benefit for this conference. So Thomas, thank you very much for being with us, and please deliver your talk.
Thanks, Peter, for the introduction. Hello, everybody in the room. I hope you are having a wonderful meeting in Budapest. For several reasons, I could not join you, and I'm going to open my presentation now. Can you see it?
Yes.
Okay. Yes. And thanks for Miklos and Peter for giving me the opportunity to talk about this topic, which is something that is very dear to us here in Marburg. And it's identifying and managing individuals at high risk for pancreatic cancer. I'll start with a statement that screening of the population for pancreatic cancer is not feasible. This is because we will be causing more harm than we will help or do benefit. So the question then is, should we screen individuals that are pre-selected for being at high risk for pancreatic cancer? And if we look at the populations at risk, we have non-hereditary chronic pancreatitis, we have smoking, diabetes type 2, in particular the ones that have near onset diabetes over the age of 50, blood group, nutrition. Wherever these groups are too big or have too low a risk to do a population screening with our current available modalities. So currently, the population that is suggested to be suitable for screening are those at inherited or familial risk for pancreatic cancer, which is 3 to 10% of all pancreatic cancers. And the biggest group there is familial pancreatic cancer, and smaller groups are those that appear as part of inherited tumor syndromes or from hereditary pancreatitis. But as you can see, the risks given here are quite variable. And the question is, which of those individuals should we screen? And within the CAPS consortium, we defined that good candidates for screening would be those that have moderate 5 to 10-fold or high, larger than 10-fold risk for pancreatic cancer. But if you look at the populations, for instance, a classical FPC family would have a 6-fold risk, just about the same like a BRCA1 part 2 mutation carrier, but it's quite different from individuals such as those with Poitiers syndrome that have a far higher risk for pancreatic cancer. Should all those receive the same screening program? What should we be looking for? I think in a hall full of pancreatologists, this is probably not the question, but we should be looking at high-grade dysplasias, either microscopic, which we will not see by imaging, or macroscopic, and in this sequence, it's the IPMNs. And of course, we should be looking for early pancreatic cancer. And in terms of CAPS definitions, a successful screening program must detect either a T1 and 0 cancer at its very earliest stage, or high-grade dysplasia. So how good are we with our current screening modalities, which is primarily imaging, in detecting these alterations? And here it's a nice study done by the Hopkins group, 225 individuals from familial pancreatic cancer kindred. And you will see later they have a pancreatic phenotype that is very specific. And they compared the output of CT, MRI, US done at the same time. And as you can see, the MRI and EUS detected a far higher number of lesions, and CT and EUS were actually better in detecting solid masses, whereas MRI and EUS were better than CT in detecting cystic masses and branch duct dilatations. So currently, MRI and EUS is superior to CT. Most centers and guidelines recommend a combination of EUS and MRCP as the best choices for screening. However, even in this a good study with from a highly experienced group, only 5 of the individuals went to resection, and only 3 of 5 had high-grade dysplasia, so a very low histopathological yield. This has not improved over the years. This is the study that done by Caspar Overbeck and Marco Bruno, who's certainly among the audience. Hi Marco. They basically found the same. EUS is better than MRI and MRCP for solid lesions. For cystic lesions, MRI is better than EUS, but not for cysts larger than 1 centimeter. And for most abnormalities, you would do both modalities is better than doing one alone. So let me move to the data we have from our German familial pancreatic cancer registry. This was founded in 1999, coordinated by my surgical colleague, Detlef Bartsch. And this is specifically for those individuals that have 2 or more first-degree relatives with a confirmed diagnosis of pancreatic cancer and without any evidence for another inherited tumor syndrome. This is important because this means that we don't have FAM-PC family members and we don't have Peutz-Jeghers family members in our cohort, which makes it a bit different from other cohorts. In the meantime, and this is the data just recently reported by Detlef in a German doctor's journal. We had to do this because we wanted to raise awareness in Germany, but probably most of you have not seen this. It's 134 families in surveillance, 295 high-risk individuals in screening, and of these, 10% are susceptibility gene mutation carriers. As most others, we're doing a combination of EUS, MRI, serum tumor markers at baseline, and then annually if nothing is found. And we changed our protocol some years ago to EUS at baseline and every 3rd year, because there was simply no output for doing it annually. We would do EUS and FNAB for suspicious lesions, and we would start screening 10 years before the youngest age of onset, or at the age of 40, whichever occurred earlier, and we changed that as well. In the meantime, we have a median follow-up of 41 months, and we have a 5-year of follow-up for about 110 high-risk individuals. And what do we find in imaging? For those who are familiar with this is, in the meantime, this is state of the art. You do see features of chronic pancreatitis by EUS. Ductal features, parenchymal features. There are several ways of documenting this. We use the Wirsema criteria because they are easy to do. You can use Rosemont as well if your endosonographist has the time to do this. More than 1/3 of the FAPACA family members have these signs of chronic pancreatitis, and this is confirmed as well in other studies here from the Mayo Clinic. They were found that high-risk individuals have an odds ratio of 50.8 to have more than 3 chronic pancreatitis changes. This is just the phenotype of the pancreas. We find a lot of lesions, as I alluded in one of my last slides. There were 187 lesions in those 295 high-risk individuals. 2/3 of the lesions were detected at the first presentation. And of these, only 5 were hypoechoic areas or masses. This is important since an unambiguous solid lesion that is larger than 1 centimeter or seen by multiple imaging modalities would be considered a good candidate for resection. However, what we do see is rather something like this. These very ambiguous inhomogeneities in the pancreas. And when you're not sure, you stick a needle in this lesion, as you can see here. In the end, only 2 of those hypoechoic areas or masses were unambiguous and were found to be pancreatic cancer. Mostly what you see is ambiguous, and none of the biopsies did help us in any case. Cystic lesions is the predominant type of lesion you find in all imaging modalities. And these are multicystic branch duct-like IPMN lesions. They are small and rarely reach the Sendai, Fukuoka, or European guidelines for criteria for resection. So we went to resection in 16 high-risk individuals. This is a very low resection rate, basically the result of our experience when we did the first resections. Seven total pancreatectomies, 2 partial pancreatectomies, 7 tail resections. And of these, 2 had pancreatic cancer, but not early cancers, so failure of surveillance. 3 PANIN-3 lesions, success of surveillance. Some pathologies that you would not necessarily resect. The same is true for benign lesions like serous cystadenoma or focal fibrosis. Overall, you could say that 68% of the resections were unnecessary because you would not have resected them if you had known what you had in hands. We made a correlation to the mutation status, and here in our series of resections, we could find no correlation to the presence of a germline mutation. Overall, our diagnostic yield was 4.5% after at least 5 years of follow-up. This is better than what we reported earlier, which was around 2%. And it seems that it gets better the longer you do the follow-up. And if you compare it with a Hopkins series, you end up with 7% after 16 years. So when you resect for cystic lesions, is that the lesion that is really the one that matters? And Detlef Bartsch and Günter Klöppel looked at 4 total pancreatectomies at some time, which were resected for they had some smaller changes in the cystic lesions. And if you look at the pancreata, you will see they all have multifocal disease. And the area of highest dysplasia was somewhere else, but not in the cyst. So this means that when you do a partial pancreatectomy for the cystic lesion, you will probably not solve the problem. When should we start screening? This is an important question. And as you remember, we started at the age of 40, but we moved now to 50. Since as you can see here, none of the pathogenic lesions was found before the age of 50. So it appears to be safe to start at the age of 50, with the exception of those families where it runs at a very young age. How does it compare to other screening cohorts? And until last year, the biggest cohort was the one from the CAPS consortium, with 354 high-risk individuals with this long 16-year long-term follow-up. And as you can see here, the cumulative incidence was 7%. And what is more, was one of the first trials that could show when you detect a PDAC within surveillance, the survival is much better than if you detect it outside of surveillance. It's the 3-year survival was 57 versus 8.9%. However, even here, we had 43% pathological diagnosis of lower grade neoplasms that you would probably not have resected. There was a follow-up study when they looked for germline mutation carriers, and they could find that the germline mutation carriers had a hazard ratio of 2.85 to have high-risk lesions as compared to a conventional familial pancreatic cancer family. Another very interesting study, again, by Caspar Overbeck and Marco Benoit and Yuna Kahan, concerns the timeline of the development of resected incident pancreatic cancers and high-grade dysplasias. And this is the data produced in 16 international programs, including ours. And there were 28 high-risk lesions in 2,500 screened individuals, it's 1%. Of these, only the smallest part were really lesions that would be considered success of screening. So the majority were advanced tumors, which we could call failures of surveillance. And what is mostly depressing is that some of those were even detected at the time of screening or appeared a couple of months after the last screening event. So we are not very good here. What is interesting from this study is that concerning the question, I said, is the IPMN only an indicator lesion? It appears indeed so that some lesions develop newly. These are mostly the solid lesions, but there were as well 54 lesions that progressed from a previously visible, mostly cystic lesion. So there are obviously two pathways for pancreatic cancer to develop in these individuals. So what can we do to improve things? Can we further select individuals for their risk? And here we did a study together with Hans Waassen from the Netherlands and Alfredo Carato in Madrid. Where we compared the phenotypes of individuals from FPC and BRCA1/2 families and from CDKN2A mutation carriers. And indeed, they appear to have a quite different phenotype in terms that the CDKN2A mutation carriers don't have a phenotype with cystic lesions. It's only about the same frequency as in the normal population, whereas as this is the case for FPC and both as well the BRCA1 and 2 mutation carriers. In contrast, the pancreatic cancer rate was much higher in the CDKN2A mutation carriers, and the survival as well here was better for individuals diagnosed in surveillance. So it appears that screening in CDKN2A mutation carriers makes a lot more sense. You probably should start earlier to screen here as in families with FPC. And this is confirmed by the most recent study, again by Caspar Overbeck and Marco Bruno, with a population of 366 that have a 10 times, an estimated risk of 10% of pancreatic cancer, with a very high number of patients that are germline mutation carriers, almost 50%. And the overall cumulative incidence was 3.1% after 5 years and 4.7 after 10 years, which confirms that the longer we follow up, the more cancers we will find. And what was most surprising here, which as well is in line with what we find, is that there were almost no incident tumors in the FPC family members. And the cumulative incidence in the mutation carrier family was 6.5% at 5 years and 9.3 at 10 years. And of the incident cancers, 4 presented as metastasized cancer, again showing that our current imaging modalities are insufficient. So what is a success? Should we really do this? And Detlef, I, and Peter Lange some time ago made a calculation based on about 1,000 high-risk individuals in screening. Here, at that time, 2.5% of the screenings would have been considered successful. We can probably increase this by simply having those individuals in long-term follow-up for decades. And we can further increase this by primarily looking at mutation carriers. However, we always have to bear in mind we can do harm. We will probably still resect benign lesions or low-grade dysplastic lesions, and thus create significant harm. Overall, we have to be aware that genetic risk populations differ in pancreatic phenotype and pancreatic cancer risk. This is particularly true for CDKN2A family members and Peutz-Jeghers family members. They need different screening protocols in the same way probably as mutation carriers that have a higher risk than pure FPC family. The branch-stack IPMN-like lesions are about the most predominant lesion type in FPC family members. They probably should be screened as we do in the normal population. And we still cannot reliably distinguish low and high risk lesions. We still don't know what the optimal screening intervals are. Looking at the study from Caspar that shows that people developed advanced cancer a couple of months after the last screening visit is simply not good enough. We should be aware that disease is multifocal and probably partial pancreatectomy is not the solution. And since there are so many open questions, I clearly advocate that screening should be done at centers that have a lot of experience in managing high-risk individuals for pancreatic cancer. Thank you very much.
Questions, please? Can I Dr. Thomas, what is the protocol now for PRSS1 carriers?
Well, there is so far, actually, I'm just writing the German guidelines for screening, and there are no good protocols. What most people do is that they start about 10 years before the before the youngest age of onset in the family, or after at the age of 40, or 10 years after the onset of disease. Yeah, because it's clearly a function of disease there. And there is a lot of discussion whether this should be done via EUS. There's some people that say that this will only give you unspecific results, or if you should do this with CT. Perhaps here CT is better, we don't know. Clearly there are even more open questions for hereditary pancreatitis than for familial pancreatic cancer.
Very interesting talk. My question relates to the skill of the clinician doing the screening test, be it EUS or MRIs. For if you want to sign off the high-grade dysplasia, and if you're a pathologist, you would ask someone else to sign off as well your results. So at least two pathologists would look at results. If you're a colonoscopist doing colonoscopic surveillance for cancer, you have to produce some key performance indicators, and I would be interested in the kind of the approach towards this problem, because you want to detect something very, very tiny or unconspicuous in the pancreas. How do you deal with that problem?
This is actually just the reason why I'm recommending that this should not be done outside of centers of excellence. Because as you can see, even if you do a lot of these screening imaging examinations, you will still end up with 50% people that you resect without necessity to do so. Yes, and there's clear evidence that in particular when doing EUS, that this is a function of experience. Clearly only highly experienced US aficionados should be doing this. And this is clearly as well one of the reasons why, for instance, the Johns Hopkins results are so good, because there are some excellent people doing this. And this is nothing to be done at a community hospital, or nothing to be done besides the usual routine. You must have a special program. For us in Marburg, we have Tuesdays and Thursdays is FAPACA day, and we have scheduled 2 to 3 FAPACA family members that are screened, and this is done by the most experienced endosonographists. This was at some time, this was me, but now with someone else. Yeah, it's not easy. It's easier for if you have a CT scan or an MRI scan, because you can always get a second opinion. And of course, if you do biopsies, which we're not doing very frequently, you definitely need a second pathologist. I agree.
Thomas, this is a very interesting presentation. I'm just curious, in your cohorts, did you find a big difference in incidence when you have, you have either 2 or more family members, but if you have 3 or 4, was there a big difference in your pastor rates?
Not measurable, not in our cohort. It would be expected that if you look at the whole population, perhaps it is something, again, for a task for Casper to do, to take all the data together. But in our cohort, this is not statistically significant.
Is it because the cohort size is small, that if you have a cohort, how about if you merge all the, I'm sure it can be done with the other cohorts, if you merge them and then...
Sure. This is what Casper did with the timeline study. And this is perhaps, as I said, a new task. Marco, you should tell him for his next study.
There is a problem with that, because it depends in which country you live, how well defined then you have a problem. Because the finance system is such that a lot of people don't want to get genetic testing. So they want to enter a program for surveillance without genetic testing, and then you do not know the background of that patient. So where then do you put that patient? In a mutation group or in the, that's one. And the second issue with regards to the risk of known pancreatic cancer, families are getting smaller by the year. Mm-hmm. If you don't have family members, you won't have affected family members. So it's very difficult to deal with that.
Absolutely. Couldn't agree more.
If there are no 3 members in a family, how are you going to do that?
Thank you for the great discussion. Thank you, Thomas. And
you're welcome.
Before we move on, I'd just like to say that whoever is online joining us, please feel free to just ask questions anytime.